I'm Jeff Postma. I'm Dr. Postma, and thanks for coming tonight on a beautiful night. I'm going to talk to you a little bit about arthritis and hip pain. So a little bit about myself, my background. I'm a Michigan native. I was born and raised in Holland, Michigan. I went to Holland High School, and from there I spent 14 years at Michigan State. I always tell people I couldn't get it right the first time, so I can actually say I graduated 3 times from Michigan State. So I did my undergrad at Michigan.
What you want to be?
Yeah, I did undergrad at Michigan State, and then my medical school was at Michigan State, and then my residency, although it was in Flint, is actually part of Michigan State University also. So I've been in an orthopedic practice since 1997. I've done about 1,500 joint replacements. Currently, I'm at Community Bone and Joint in Coloma, and I practice here at Watervliet. This is where I do all my surgeries, and we have a joint unit upstairs for the joint replacements. So a little bit about what we're going to kind of talk about and things I'm going to try to touch on. I'll talk a little bit about the basic anatomy of the hip, tell you a little bit about what hip pain is, kind of my breakdown of it, and certainly kind of concentrate a little bit more on the arthritis of the hip. Kind of the 2 most common ones. We'll talk about the signs and symptoms of that arthritis and the conservative treatments, and then the surgical treatment being hip replacement or resurfacing of the hip joint. So the anatomy of the hip. Everybody kind of talks, and they point to their hip, and typically people point to their hip joint, and they always point right there on the sides. And that's not really where the hip joint is. The hip joint is really right here in the front. So what we kind of typically point to is that's our pelvis. And so we have the pelvis and the femur, and this is the bone that we typically feel right on the side of the hip, is just this portion of it. And when we look at the actual hip joint, it's a ball and a socket. And the socket is what we know as the acetabulum. So, and then the ball, the femoral head, fits inside of that. So that's why it's kind of deep. Right in the center is where that hip joint is. The muscles come around that. The muscles attach to the pelvic bone, both on the front and the back. This is your sit bone, so that's where your hamstrings attach. That's what moves your leg backwards, and the muscles in the front attach up across here, and then there's muscles that lay across the side of the hip also, and that's what helps us bring our leg out to the side. So when we talk about wear and tear of the hip joint, you have to know about the cartilage of it. So cartilage, I always tell people, my background was in auto mechanics, and that's what put me through college, and so I always use a lot of analogies that go with mechanics. And so, the cartilage is sort of like the tires on your car. And when you drive your car 80,000 miles, what happens to the tires? That tread narrows down. So that cartilage is your tires. So it covers the joint. So it covers the socket, it covers the ball. It's what cushions and protects it, provides that smooth gliding surface into a joint. So when we talk about hip pain, I look at hip pain, and I always have to kind of, whenever somebody comes in, I have to take and I kind of divide hip pain into hip pain that is from the hip joint, and then hip pain from outside the joint. Now, everything that causes pain inside the joint eventually leads to an arthritis, a wear and tear. So, and those are, femoral acetabular impingement. This is kind of a newer kind of diagnosis that we have for the hip, in that we know that there's kind of a bump right along the side of the ball. So normally you have kind of a ball, and you have these kind of corners that fit, and sometimes that ball kind of goes flush right with the side, and that causes a pinching onto the socket. And so there's some things that can be done where we actually kind of remove that bone spur, or that edge of that bone. We look at the labrum, the cartilage rim around it. and that can cause a pinching inside the socket. So that's some of the things that can happen early, but those things can lead to a wear and tear. And then the primary osteoarthritis, which I'll talk a little bit more about in detail in a minute. There's hip dysplasia. Hip dysplasia is more of a, what we call a birth defect. It's an abnormal shape to the socket, and that can lead to an arthritis. It used to be known as congenital dysplasia of the hip, or developmental dysplasia, or a congenital hip dislocation. So when a baby was born, the hip was dislocated, it was held into the socket, but sometimes that socket becomes an abnormal shape. And then fracture. So breaking a hip, breaking into that joint. We can also have stress fractures that can cause pain into the hip joint. A lot of times these things go undetected until it's at a point that requires a surgical treatment with hip replacement. So the other things that we look at are the things outside the hip. They don't necessarily lead to an arthritis of the hip, but can cause similar symptoms. Muscular symptoms, the strains, tendinopathies. So everybody in their life has probably done something where they slipped and all of a sudden they had the pain in the front of the leg or pain in their butt cheek from slipping on the ice, and that's more of a muscle strain. Give it a little bit of time, a little bit of rest, ice, heat. You start stretching it and it gets better. I know, where's the baseball player? He left. Oh my gosh. So I'm sure he's experienced it, probably sliding into base at one point. He had some type of a strain on his hip. Piriformis syndrome. Piriformis syndrome, people talk about having sciatica. Well, the piriformis muscle is a muscle that lays right across your butt cheek, and the sciatic nerve runs right behind that muscle. And it can cause a lot of pain into the back side of the hip. It's kind of right along the lines of a muscular or a muscle strain or a tendinopathy. The other symptom or the other diagnosis is iliotibial band syndrome. This is real common in runners, is where I see most of this. And it's a pain that is along the side of the hip and runs all the way down to the knee. It's such a strange thing because some people have pain just at the knee, other people have pain just at the hip. This band of tissue runs from the top of the pelvis down to the side of the knee. And for some reason, that band can get tight, and it actually causes a snapping sensation inside the hip. So when you move up and down, you get a snapping. So it happens commonly in runners. Runners tend to run on the same side of the street. Streets have kind of a curve to them, so essentially they're running with one leg longer than the other all the time and tend to get it on the same side all the time. It's kind of just a unique thing. And it's my son is a runner, and of course he has been plagued with everything on here. And then bursitis. Bursitis is something else that's very common. Bursitis is what a bursa is just a potential space. It's not real, it's there. It's a space that lets the muscles glide over top of the bone or muscle glide over another bone. And that spot that we point to on the hip, that bone right there, that's called the greater trochanter. And that greater trochanter is where muscles attach to help us turn our leg in and out. But the iliotibial band lays right over the top of that. And if you do something that you fall, you land on it, you can get inflammation of the greater troch. Sometimes, because of an injury somewhere else, you may limp for a while, and that will cause a greater trochanteric bursitis. It can be quite plaguing, and some people, most people, we do the simple conservative things, we can alleviate that pain and it can go away. Some people have such changes that they wind up having this tendinopathy, which is an abnormal tendon that leads us more towards a surgical treatment of that type of a hip pain. Sometimes you can have arthritis, something happening inside the hip, and these things going on at the same time. So sometimes it's just a matter of relieving one of the pain to make a big difference. So the non-arthritis hip pain, what do we do? Number one, determine the cause. Hopefully determine the cause. Mainstay of a lot of our treatments are anti-inflammatory medications, the Motrin, Advil, Aleve, ibuprofen. They help to decrease the inflammation. They're used short-term, hopefully to alleviate the symptom. Physical therapy and exercise. The exercise program is really a stretching program, or it's strengthening the other muscles, because a lot of times you have pain in the hip or you have pain at one of the muscles because you're overusing the others. That's kind of the idea of that iliotibial band syndrome or a greater trochanteric bursitis. So the physical therapist can really help us in the exercises and the stretching to alleviate those. Cortisone injections. We use cortisone injections around the tendons and around those muscle areas or into a bursa to decrease the inflammation. It's always a great option to try. You know, we usually don't burn any bridges by trying to alleviate that pain. And then when the conservative things fail, we look at the surgical treatment to try to alleviate symptoms. So arthritis, that's kind of the big topic. That is the main thing that we see in the hip. Like I said, all the things that can occur inside the hip joint as a hip pain that can go on for years eventually lead to some type of arthritis. So arthritis is an inflammation of the joint. There's swelling inside that joint. Most of the time it's the swelling that causes the pain. Like I talked about, you know, there's so many different causes of pain inside the hip. There's over 100 different types of arthritis that we can talk about. So over 43 million people are affected each year with some type of a hip pain or an arthritis of the hip. Like I said, it's pain, swelling, loss of motion. It's the number one cause of disability in the United States is arthritis. When we look at arthritis, there's two different types, two main types that we talk about all the time, and that's osteoarthritis and rheumatoid arthritis. Osteoarthritis, this is what is known as kind of the wear and tear. So if all the problems that I talked about before causing pain inside the hip eventually lead to an osteoarthritis, a wear and tear of some sort. So it's the most common type of arthritis. In 2011, 28 million people had osteoarthritis. And by 2020, 60 million people are expected to be affected by osteoarthritis. I put in there, it's a degenerative disease affecting the joint cartilage. There's a couple terms in medicine that I really detest. Degenerative is one. Degenerative sounds like it's breaking down and really falling apart. It's a slow process. It's not as bad as that word actually is. It's a wear and tear. And that's the best way to think of it. It's a gradual wear and tear. It's that tire going down that road. Eventually that tread becomes thinner and thinner. So osteoarthritis, it affects the knees, hips, back, hands most commonly. So we see that, you know, the most common things that we see are the knees and the hips. So there's no specific cause of osteoarthritis. There's several different factors that lead to the development of that arthritis. Increasing age. Anybody over 50, you got some wear and tear and you wind up getting some osteoarthritis. Family history. There's a really strong connection of a family history of osteoarthritis that's passed down. So, you know, you can blame your mom. Previous injury to the joint. That's what I was talking about with having a fracture into that joint, a stress fracture, having developmental dysplasia. That's a type of an injury to that joint that causes a more rapid wear and tear to that joint. Obesity. Being overweight causes a wear and tear to the joint. It's One of my colleagues always kind of jokes and says, you can run a semi on Volkswagen tires just so long. And that's kind of talking about that overweight, that, you know, there's just so much that the joints can handle. And then the improper joint formation. That's what I talked about with the developmental dysplasia or dislocation of that hip joint. So usually osteoarthritis, it starts as a small area. There's just a small area of wear to that joint, just an abnormal portion of that cartilage that starts to have wear. And then it progresses over time and becomes a larger surface area and affecting more and more of that joint. Eventually, as that cartilage wears, you get bone on bone. Or like my analogy is, the cords on the tires start showing. You know, the tread's completely gone. In the case of the hip, you know, it results in pain, it results in swelling, and usually stiffness to the joint. And that's sort of our body's reaction with that stiffness is, it says, hey, you know, this is hurting every time it moves. And the body's reaction is, everybody heard about developing bone spurs, is you kind of develop bone spurs around the joint. You get that reaction, and it's kind of the body's idea of saying, hey, it hurts when we're moving, so we're forming these spurs to make the joint stiffer and trying to fuse it, so trying to alleviate the pain that way. The other type of arthritis that we hear about is rheumatoid arthritis. Is that better? Sorry. So rheumatoid arthritis, typically people are diagnosed with rheumatoid arthritis at a younger age. Rheumatoid arthritis affects usually multiple joints. And rheumatoid arthritis isn't really a disease of the joint, but a disease of the joint lining. In that excessive fluid that the lining makes actually goes in and kind of, here's another word that I really don't like, destroys the cartilage. It thins the cartilage and makes that joint so it's worn out. So, and that's what that pressure leads to, the erosion of the bone, the erosion of that cartilage. Rheumatoid arthritis, that's probably what you see all the advertisements for. And I can tell you that almost every magazine you pick up off a store shelf has some type of advertisement for a rheumatoid drug. You know, Nalapril or Exparil. There's a lot of disease-modifying drugs, and that's what my colleagues in rheumatology, they can utilize those medications to help modulate that disease to decrease the inflammation. So the symptoms of arthritis. The typical symptoms are pain that slowly develops, worsens over time. It's pretty rare that all of a sudden, boom, you have pain and it stops you. Although that can happen when you're doing something that's probably a little bit more strenuous. Taking and aggressively vacuuming, twisting and turning on the hip, and all of a sudden having tremendous pain. So sometimes it does happen relatively quickly, but it's something that slowly happens. Like I said, it's usually pain in the groin. It's that deep, kind of boring pain right in the middle of the groin that that is from the arthritis. Arthritis of the hip, a lot of times it's pain in the front of the thigh that goes down towards the knee. There's a nerve that lays right near the hip joint, and it gives you feeling to the front of the knee. And so a lot of times when people have hip problems, they actually feel it right in the front of their knee. So pain usually flares up with some type of vigorous activity. And then again, the stiffness to the joint makes it difficult to walk or to bend. Sitting in a chair for a period of time, getting up from the chair, those are the things that typically people complain about. So you feel a locking or a sticking of the joint. That's very common with the hip. You can feel that. And sometimes you can actually hear a noise. You hear that gravel sensation, the grinding into the joint. It's that decreased range of motion. affecting that ability to walk, causing a limp. And then that's what causes the muscle becomes a little weaker with that. Weather changes. The rainy, cool, damp weather, for some reason, causes that joint to ache more. A lot of theories on that. There's nothing really medically proven. It's always been described as that you have a contained joint and it has fluid in it, and same as the barometer, that when you have a high pressure center comes up, the pressure goes up. So inside that joint, you probably have an increased pressure inside that joint during a high pressure, and that's what causes pain. That's the best explanation I've ever had, and I like it. So, that's gonna stick as my number one theory. So what do we do with arthritis of the hip? Number one, get a proper diagnosis. Looking at the medical history, looking at the symptoms, health, activity, kind of differentiating what's causing pain from the inside of the hip, or is the pain coming from the outside of the hip? You've got to examine the joint. We always check the range of motion, tenderness around the hip, because that finds the problems outside of the hip joint, and looking for other joint deformities. X-rays, we certainly use our X-rays as a screening tool to really look at how severe the arthritis is. Orthopedic surgeon as myself, we can help with that advice and that treatment. So X-rays, they determine the severity of the joint damage. We can't see cartilage on an X-ray. So cartilage doesn't show up. The bone does. So we always look at the space to look at healthy cartilage. So on this X-ray, you can see that there's space. So here's the ball. Here's the socket. This really white line up top is called the sourcile, French for eyebrow. So you see this dark space that's in between here. That's what a normal joint. So when somebody has arthritis, that wear and tear, that space is gone. They've developed this bone spur here along the edge. The whole joint is whiter, and so that's severe arthritis of the joint. So what do we do? What can be done when people have arthritis of the joint? I always tell people I look at all my treatments as a pyramid. We start at the bottom of the pyramid. Bottom of the pyramid is you do nothing, you live with it. And then above that, you kind of work your way up. And it's doing exercise. Part of arthritis is you use it or you lose it. You maintain that motion to that joint. So, and that's what I talked about with the physical therapy, doing stretches, maintaining strength of the other muscles around the hip. That's very important to do. You look at lifestyle changes. Surgical treatment and other treatments that are not for everybody. And some people are comfortable with just being more of a sedentary than trying to be active and being up on it all the time and doing things that cause pain. Diet and weight control. The rest, the ice, the heat, those things help with the symptoms of inflammation to the joint. Medications, there are anti-inflammatories, there's supplements, the glucosamine chondroitin sulfate. That's been around for a long period of time, and certainly some people get help with that. Walking aids, injections, and physical therapy. So kind of hitting on each of those, what does exercise actually do? The cartilage inside the joint is not really a true living structure. It has a blood supply from the back side, but the center portion or the main portion of the cartilage gets its nutrition from normal joint fluid. And so by exercising that joint, you maintain lubrication of that joint. So that's how exercise is beneficial. It helps lubricate, prolong the life of the joint. It keeps the joint limber. Of course, helps create strong bones, and that's a whole nother issue of the osteoporosis that can occur. What type of exercises do you do when you have arthritis? You know, I hear that all the time. I can't exercise because my joint hurts. Definitely so. So we look at partial weight bearing, or what we call non-weight bearing exercises. So walking is more of a partial weight bearing exercise. You know, you're not stomping down on it. You're not creating an impact. We look at, you know, high impact aerobics or running as a high impact activity. Swimming. Swimming is great for maintaining muscles. It is a non-weight bearing exercise, so you're never putting weight down on the joint with swimming. Bicycling is a non-weight bearing exercise. You maintain that motion, but don't put weight on it. As well as water aerobics, other low impact activities, the golfing. We actually consider kind of doubles tennis as a low impact activity. Tennis, doubles tennis. Yeah, doing singles tennis is considered a moderate impact. So, modifying activities. So, maintaining good posture, lifting correctly, doing light exercise, adequate rest. We know a lot of healing occurs with rest. Maintaining ideal body weight. You know, that's weight control. So, for every pound, there's 3 pounds of force across the hip joint. So when you're lifting your leg up and normal walking, 3 times your body weight goes through your hip joint. Versus standing and jumping on the one leg, that's 7 to 8 times your body weight is the force that impacts down onto that hip joint. So you look at that, you lose 10 pounds, that's 30 pounds of pressure removed from the hip joint. We know that every study, there's actually the studies that are done, okay, it accelerates the destruction to the cartilage, makes it harder to exercise beforehand. The more recent studies have shown that everything we do conservative, the only thing that stops or the only thing proven to help arthritis of a joint is weight loss. So that's the only thing that can occur. Now, with all that being said, people of ideal body weight still develop arthritis. You don't have to be overweight to have it.
Are you saying that it can regenerate?
No, it's not going to regenerate, but it's the only... Once it's destroyed, the cartilage is gone. Yes. Yep. So same as the tires on a car. You know, you can't park the car and say, hey, my tires are going to get better. You know, they're still worn.
Something you said a while ago sounded like by losing weight.
Yeah. So like I said, you know, with all the conservative things we do, with medications, exercise. Those things, they don't build cartilage. The anti-inflammatories, you know, I prescribe anti-inflammatories. I think anti-inflammatories do help. But the studies that have looked at using anti-inflammatories and looking at weight loss together, the only thing that has really helped people in the long run was weight loss. So with that, that's kind of the next point, the anti-inflammatory medications. You know, there's ibuprofen, that's Motrin, Naproxen, that's Aleve. There's Mobic, Voltaren, Relafin. There's 100 different anti-inflammatory medications. They do work. They reduce swelling. They do what they're supposed to. There's a lot of problems with anti-inflammatories also. They affect the kidneys. They're cleared by the kidneys. So they can cause renal failure. They can cause kidney failure being used long term. Stomach. They can all cause ulcers in the stomach. They can all affect blood pressure, some of them more than others. They have side effects with the blood platelets. That is your clotting factors, so the ability for your blood for you to stop bleeding if you're cut. So anytime you use those, like I said, I prescribe them. They work great. They're short term. They're not meant to be used for years and years and years. They're short term use. So always talk to your doctor, and especially, with so many of them on the market, the ibuprofen and the naproxen, we tend to forget that we're even using those medications when you talk to your doctor. So please, let them know that you're taking the over-the-counter medications also. So the over-the-counter medications, the acetaminophen, Tylenol, that's number one use for pain. And, again, medications have side effects. We know that acetaminophen can cause liver issues with taking too much. So there is a maximum amount. So when you use Tylenol, follow the directions on the bottle carefully. Aspirin was kind of the first anti-inflammatory. Aspirin works great as an anti-inflammatory and a pain reliever, but has side effects. And then I talked about the naproxen and the ibuprofen. Self-help devices, canes and walkers. So a cane reduces the stress across a joint. So using a cane in the opposite hand of the affected joint reduces the amount of pressure on that joint by 50%. So it really does decrease the amount of weight that you're putting through that joint. And so, bottom line is you can use it in whatever hand you want, but most people don't walk like this. So if you move your right foot forward, your left hand usually goes forward. So that's why we say use it in your opposite hand. So walkers and crutches. So good, especially if your gait is unsteady. A walker is really important to prevent you from falling. It provides that support, balance, also helps to reduce pressure on that joint. Cortisone injections. So cortisone is your body makes cortisol. That is your body's natural cortisone. You have to have cortisol in your system to live. So cortisone is a little bit of synthetic cortisol. It's the exact same structure. It's an absolutely fantastic anti-inflammatory that can be used to decrease inflammation. Especially if you have a greater trochanteric bursitis, we do an injection on the side of the hip. There's a good chance of totally alleviating those symptoms with a cortisone injection. The problem is long-term use. With long-term use, it can cause destruction of the joint. So it can actually cause damage to the cartilage. So we hold pretty hard fast that 3 to 4 injections in a 1 year period of time. We know that that is kind of a safe injection amount. The hip joint is very difficult to get into. It's not like a knee joint. The knee joint, you can feel the edges of the knee joint and get a needle into. The hip joint is very difficult to get into in that it requires X-ray to see the joint to get into it. So it makes it more difficult to inject into a hip joint than some of the other joints. If we need it as a bridge to get somebody, to get the inflammation down, to help for a short period of time, for timing of things, then an injection is good. Also with cortisone, if a cortisone injection is done, we want to delay surgery for 10 to 12 weeks before an injection is done. We know that there's a higher risk of infection if a cortisone is put into a joint before we do any type of surgery. So we kind of worked our way from the bottom of the pyramid, doing nothing. Above that, using anti-inflammatories, physical therapy, exercise, weight loss, cortisone injections. Kind of the top of the pyramid is surgical treatment. And that's deciding, when the conservative treatments failed, when the pain is to a point that people can no longer stand it and it's affecting their daily life, then you want to consider proceeding with a surgical treatment. Certainly having an evaluation with an orthopedic surgeon, educating yourselves like you're doing here to know what the options are and what surgery is all about. The benefits of a joint replacement: it can eliminate or reduce the pain. You know, the original motto was put by God and put in one way, and we are not Him. And, you know, joint replacements, they work fantastic, but there is, you know, some pain that can still occur with them. It dramatically reduces people's pain. It really enhances their mobility. It can improve their quality of life. A lot of them return to very normal activities. You know, we recommend low-impact sports. I have a neighbor who I did a hip replacement on. I did a replacement on him 12 years ago, and he's having his other hip done next month. And he every year, he says, I got to water ski. And he water skis at least twice a summer on his hip replacement. And he said he never could do it before his hip replaced. So I'm praying this summer after it's done, he's not going to water ski this summer. That's not what I consider a low impact, but those are the things that, you know, you can get back to doing a lot of normal activities. So replacement is another term in my field. I really don't really like the term replacement. It just seems, it makes it sound like I'm cutting it out from here to here and replacing out everything in between. It is more of a resurfacing. You know, the medical term for replacement is an arthroplasty. So arthro means joint, plasty is surfacing, so it's surfacing the joint. So we replace that damaged portion of that cartilage in that bone. There's various options that we look at with replacements, and you know, you look at any newspaper from any big city and you'll see something from a lawyer saying that there's a recall on such and such implant and the metal on metal implants, and everybody's nodding because everybody's heard it. So, you know, there's metal or ceramic on a medical grade plastic, and it's a ultra high molecular weight polyethylene, and this plastic has been, it's actually irradiated and it's cross-linked. It's a harder surface. It has really developed over several years. And we put a metal or ceramic against that piece of plastic. That is kind of the traditional and the mainstay in joint replacement, in hip replacement. There has been some problems when we look at metal on metal. They're virtually gone in this country at this point because of wear of the metal and metal. There's been a lot of recalls on metal and metal. People have developed squeaking into their hip when they walk from running metal on metal. And there has been the breakdown of metal. You know, when you run, you know, anybody who's been any kind of mechanic and you run metal on metal, I mean, what happens when you run the oil out of your car? You know, those metal parts break apart. So the metal on metal has kind of fallen out of favor. Ceramic on ceramic. Eventually, we may be leading more to that. I don't do much on ceramic just because of my training and my background on ceramic. You know, if you remember Bo Jackson, you know, Bo knows everything. Bo could do everything, and Bo could do everything until he broke his hip and had a replacement, and he had ceramic on ceramic. It was also a time that we had a bad batch of ceramic from the ceramic manufacturers, and so Bo broke his ceramic. And if you ever take sand and grind that against metal, it does not look good. It's like sandblasting the metal component. So I had a bad taste of ceramic on ceramic trying to wash ceramic debris out of a hip joint. So I don't use a lot of ceramic on ceramic. I use kind of a ceramic on plastic. The metal that I use, it's zirconium. It's close to what titanium is. And they oxidize the outer surface of it. And when you oxidize zirconium, you get zirconium oxide, which is ceramic. So it's metal with a ceramic surface that's built into it. So it's a metal on plastic, but it has a ceramic surface to it. So when we look at the hip joint, the components of it, in the socket, the acetabulum, we put a shell. There's a metal shell. We clean out this metal socket, kind of looks like a cheese grater, that we clean out that diseased bone, and then we put this metal shell in place. That metal shell gets impacted in, sometimes a couple screws to hold it in place, but we make it so your bone grows into that shell again. The other part is the stem. So the middle of the bone is hollow, and we just have a broach, and we kind of clean it out, and we shape that inside of the bone the shape of that metal prosthesis. And then that metal prosthesis is pressed into place so the bone grows into that. On top of that stem is the choice of head, whether it be a ceramic head or metal head. And then a plastic liner is put into that shell. So that's what the components of a hip replacement is. All the muscles are left in place. We don't do anything different to the muscles, so all the muscles function the same afterwards. So success of joint replacements. In the country, in the US, there's over 1 million joint replacements done yearly. It treats the debilitating pain and the deformity from all the various forms of arthritis. Like it says, it gives a new leash on life. You know, it improves someone's function. So how do we get into the hip joint? So has anybody in the room, just a show of hands, who's heard about the anterior approach to the hip? 1, 2. Just read about it. Yeah, just read about it in the brochure, okay. Does anybody know the difference between the anterior, lateral, or posterior approaches to the hip? No? So this has been kind of a really hot topic, and some of it may have been a little bit of advertising. Certainly when anterior approach first came out, it was really quite advertised heavily as a quicker recovery. And so I'll kind of hit on all the different approaches. So the anterior approach it's an incision that kind of is across the front side of the hip. And it's not a new approach, it's actually an old approach. It's just one that being revisited. And I do the anterior approach, and we kind of select people based on different approaches. So the anterior approach is kind of a muscle sparing. It has always been touted as kind of a little quicker recovery. It is quicker recovery at weeks 4 and 5. So at week 4 and 5, you're where everybody else would be at week 6. So you get about 2-week quicker recovery with an anterior approach. Like everything, there's always some downfalls of one versus the other. The anterior approach, you know, it was a couple years ago, it was kind of our saving grace, and when I did a lecture on hip, everybody knew about the anterior approach because it was being advertised. But they're not advertising as much because they're actually finding that there might be some problems with that approach, and that we might be having some loosening of the components early, and we might be having some higher dislocation rates with the anterior approach. So I still utilize it. It's based on a person's anatomy. It's based on what we talk about in the office. So it is an approach that can be utilized. And if you look in the brochure, you know, I think that my patient and myself are on a picture of doing the anterior approach. And and he's done very well with it. the lateral approach. The lateral approach is an incision that is about a ½ inch further to the side than the anterior approach. With the lateral approach, we actually take a muscle and we actually split the muscle to get into the hip joint. And then that muscle is repaired. So what that means is we have to protect your weight bearing, and we have to protect your weight bearing for 4 weeks after the surgery just to let that muscle heal in place. The lateral approach has the lowest incidence of dislocation afterwards. It is one that we can let people put full weight down on immediately afterwards. That's kind of my mainstay, and that's the one that I use most frequently, is this lateral approach. The posterior approach. The posterior approach is an incision that goes a little bit further to the back. We take the muscles, the piriformis muscle. We take the piriformis muscle and a couple of the other muscles, and we have to actually take that off the bone to get into the hip and then reattach that afterwards. Again, we protect the weight bearing for 4 weeks afterwards. The bottom line is that when we look at all 3 approaches to the hip, no matter which approach we use, the implants are the same, and at 6 weeks, everybody's at the same point in their recovery. I always tell people that, I work very hard. Usually a hip replacement takes about an hour and a half to do. So I work really hard for that hour and a half to get things in that perfect position, to make things so they function well. I bring it through all types of motion to make sure that I don't have a problem with a dislocation or the prosthesis becoming loose. And then it's the patient that has to do the recovery. And a lot of it is, the attitude that you go into at the beginning with is how well you progress. And you can't really damage anything we've done. So you can really push it. Like I said, you got to protect that weight bearing to protect that muscle healing. But people progress really rapidly. And with a hip replacement, that pain that you have into that, that groin pain, you come in the morning of surgery, you have that groin pain, and the next day that groin pain's gone. You have pain from the incision, but the groin pain's gone, and people get up and walk on it right away afterwards. I did a hip replacement this morning, and the gentleman that I did, he was back in his room at 11 o'clock. And at 1:30, the physical therapist had him standing up out of bed, walking into the hall and back. So that's the day of surgery, walking on it, which is pretty incredible. So why would you have hip replacement or joint replacement here, Water Lake or small hospital? We have a dedicated unit for joint replacement. It's the primary thing that's being done in Water Lake right now is orthopedic surgery. The floor where you're admitted is just for joint replacement patients. And the nursing staff, the physical therapy work just with joint replacement patients. They are pretty attuned to anything that might be going on, and that's part of me saying today, getting the patient up today, walking on it. They know exactly what the protocol has to be for everyone. And we're small enough, they ask if there's any precautions, if there's anything else that needs to be done, and we have a one-on-one conversation, and everybody knows exactly what the steps are. Our rooms are private rooms. It's considered the clean room. We also have the live-in rooms, so our couch folds out, so if somebody has to stay with you, they're more than welcome to do that here.
How many nights do you stay in the hospital?
2 to 3 nights. So, having a surgery on a Tuesday, you would go home Thursday or Friday. If you go home Friday, it's usually by 10 o'clock in the morning, just have a little physical therapy. We don't know. They're going to get mad at me. We don't have a checkout time. It's not like the hotel. So, it's kind of based on what someone's progress is. And some insurances do say that, you you're only required one, you're only allowed one night in the hospital for a joint replacement. Yeah, some people are able to do that, but some people need that extra day. I mean, there's so many variables that we have to look at, and everybody's life is a little bit different, and people helping out at home, people coming in to help you afterwards, all those things have to be kind of arranged. So that's where I say 2 to 3 nights. Mm-hmm.
I've been told that hip replacement, I was told this by a surgeon who had the hip replaced, was easier than a knee replacement. Why
Yeah.
would that be?
Yeah, it is. I don't have a good reason why, maybe because that joint is deeper and people recover better from that. The knee joint, first of all, the hip joint is a ball and socket, so it just pivots. The knee joint isn't just a hinge. It bends and it pivots. Because one side is actually larger than the other side. So when you bend your knee, it actually bends and kind of curves out of the way. So there's a lot more movement to a knee joint than to a hip. So I think it's a little tougher recovery from a knee than a hip.
What do you use for a criteria to determine when a hip replacement should be made?
How bad is it bothering you? How bad is it bothering you? It sounds a little sarcastic, but if I look at the X-rays and I see that there's significant arthritis, I can always say that, I'm not treating an X-ray. The X-ray's ripe, sure, that's ready for a joint replacement, but the person has to be ready for it. The patient has to be ready for the joint replacement. I see people that I look at their X-ray and go, holy smokes, how are they moving? And they jump up and they walk out and you hardly even notice a limp. And they've dealt with it so long that it bothers them just certain times of day. And everybody's pain level is a little bit different in what they can tolerate. So I think some people just aren't ready to have their joint replaced. So I really do kind of put it right on someone else and say, how I can tell you that the X-ray is ready. Now you got to tell me, when are you ready to have something done with it? So things that we do here for pain control, we try to use regional anesthesia more. Regional is kind of making you numb from kind of the waist down, so it blocks the pain fibers before you have surgery. That tends to help post-operatively. We do pretty strict post-operative pain management using nerve blocks, using regional anesthetic, using injectables to help, injections into the joint when we're closing to help to reduce any pain that people have afterwards. So we want to minimize any complications with a joint replacement. So we make sure that somebody's seen their primary care physician prior to the surgery to make sure that medically everything is okay so we can proceed. Dental work. You got to make sure that you don't have abscess tooth or infection to the tooth, because we know that that goes through the bloodstream and it can settle into a joint. So we always ask to make sure that dental work is up to date beforehand. Preparing the home for recovery afterwards. Picking up loose things laying around, loose rugs. Those are the things that we have to kind of watch afterwards. I do utilize our home care frequently. Our home care comes out and helps right after the surgery for the first couple of weeks to make sure that there's not a risk of fall or something else at home. After the surgery, people get back to the swimming, the golfing, walking. I had 1 to 2 months. It's probably closer to 2 months after surgery they're back doing things. I always tell people that the first 2 weeks, the first 3 days are kind of the rougher days. That's why you're in the hospital. After that, we have home care working with you with doing physical therapy. That goes until the second, third week after surgery. By that point, we're progressing you from a walker to a cane. By 6 weeks, people are out walking around, they're doing things, the pain's virtually gone, other than maybe having some incisional pain and pain on the side of the hip occasionally when you kind of push the limits. By 3 months, majority of our people are back doing the things that they want to do. Golfing, like I said, swimming, doing low impact activities, trying to avoid the high impact activities.
Can you cross your legs?
At about 12 weeks out, we let you cross your legs. Yeah, initially not, because that's how we get into the hip joint. There's some hip precautions that we follow immediately afterwards. Yep.
How long is physical therapy at? Like, do you go continue like for a couple months after that?
I usually figure that there's 6 weeks of physical therapy afterwards. Certainly with the knees, that's required. Hips, not always. I can say there's probably got 30% of the people that do home care, do the home physical therapy. They develop a home exercise program, and they don't do anything after that. So some people are certainly able to do that afterwards. So and that's why we usually follow somewhere between 2 and 3 weeks post-operatively, 6 weeks post-operatively, at 3 months, and then usually we check at about a year out. And then occasionally we have to check after that, and then usually no additional appointments after that unless there's some type of a problem. So having a proper diagnosis, differentiating between what is inside the hip versus outside the hip as a cause, seeing an orthopedic surgeon. Knowing that arthritis can be controlled. We try the conservative things. I think we always have to try the conservative things before we jump into any type of a surgical treatment. And you consider surgery when the conservative things do fail. So thanks for coming tonight. I want to open it up for any questions. We're located in Coloma on Pawpaw Ave. Jennifer Meadows, I think she's still sitting outside. She is more than welcome to set up an appointment with me if you desire to do so tonight. So